Good morning. Welcome to Grand Rounds. I'm stepping in for Betsy, who's out of town today, to introduce our speaker this morning. It's Dr. Ryan Westergaard, who's an associate professor in the Division of Infectious Disease and also in the School of Population Health. Ryan actually did his undergrad at UW, graduated in the late 1990s. What you might not know is that he was actually an All-American on the crew team his time at UW, and as I understand it, also developed his own major when he was an undergrad here. He subsequently completed the rest of his formal degree training at Johns Hopkins, including his MD, MPH, and PhD, followed by a residency in internal medicine at Colorado, and infectious disease fellowship at Johns Hopkins. We were fortunate enough to recruit Ryan back home in, I think, 2011. He was just tenured last year. Ryan's clinical work and his research focuses on infectious disease epidemics in underserved populations, particularly focusing on access to care, identifying barriers to access, and defining strategies to implement to improve access to care. He's done this in prison populations and associated with most recently with the opioid epidemic that he's going to talk to us about today. He's been well recognized for his expertise in this area, and in 2016, in fact, received an NIH Director's Innovator Award for the study of this growing problem. So with that, I'll welcome Ryan to the stage.
Good morning, everyone. It's a true honor to be here and to be able to present Grand Rounds for you today. And I want to particularly thank Dr. Trowbridge and Dr. Andes for supporting our group in talking about this topic in particular. A major theme of my comments today are going to be about the value of team-based care, and so I wanted to start by acknowledging the very large and supportive teams that I get the pleasure to work with on this first slide. Our research group in the Division of Infectious Disease has helped very much with the actual science that I'm going to be discussing and often the graphics that I'm going to be showing. And far too many people to identify by name, but our team of providers and support staff at the AIDS Resource Center and UW Health Clinic have been instrumental for the work that we're going to present. This is my disclosure slide. And this is the roadmap for our talk today. The first learning objective is to understand how federal funding programs and health innovation systems have contributed to the controlling of the epidemic of HIV/AIDS. Second, I want to identify and review some of the evidence-based interventions that I argue have the greatest potential for reducing opioid-related deaths among people who use drugs. And then finally, I want to challenge us to recognize how direly we need improved implementation of evidence-based interventions in order to turn the tide on this current epidemic. So a format that I'm going to use frequently is a juxtaposition of these two global epidemics of premature mortality that we're living through currently. On the left is the epidemic curve of the HIV/AIDS epidemic. On the right is the epidemic that we're currently living through that involves deaths due to opioid overdose. As you can see, in 1993, 1995, we turned a corner in reducing age-related mortality. We've not yet done this for opioids. And so my goal for today is to talk about what can we learn from how we've done this in terms of developing systems of care to take care of people living with HIV. I believe the best way to understand the systems of care, for those of you who haven't been a part of it, is to actually talk with some local experts. And we're very honored to be joined by two special guests. And we're going to pause for a couple minutes to talk with Rachel Welsh, who's one of our medical case managers and a social worker, and Mr. B, who is a patient of ours, who has graciously, both today and in previous community events, given us permission to share his story and talk about the care that he's received. So thank you both for being here. Your microphones need to get switched on, I think, before
You're ready.
They've done this before. They know what they're doing. So, Mr. B, the goal of our talk today, and what I wanted to share with all the doctors and researchers in the audience, is what might be special about the kind of care that we receive in our clinic. And I asked Rachel, who you know well, and Nora, one of our other case managers, if they could think of a person who's benefited from the unique kind of care that we provide. And both of them thought of you immediately. So my first question is, do you agree with them? And if so, why?
I do. Good morning. I agree. I've benefited tremendously from the team at UW. Not only I consider UW a one-stop shop at the clinic because they involve everything as far as care, whether it be mental issues, which I may have sometimes, whether it be any other kind of distress that I'm going through. Rachel is always my go-to person, not just with meds or medications, but whatever I need. So they're always there for that.
Have there been specific things that have happened in your life that have made staying engaged in HIV care particularly challenging?
Yeah, my life can be very distressful at times. Not so much with med adherence, because Rachel knows I'm an adherer to medicine, so I never miss my meds. But my life can fluctuate from good and bad sometimes. So when I'm in those distressful times, I pick up the phone and I call the clinic, and it's usually Rachel, sometimes Nora, or Sarah, who's my provider. Any of them, they'll stop and drop what they're doing, and they'll talk to me, and they'll find out what's going on and how they can help. And they always do.
What are some of the things that they've been able to do in terms of getting you referred to other services, or what are some of the things that they've done?
I cannot begin to start. Everything from helping me get eyeglasses through UW to physical therapy to any other kind of services, helping me to get my meds, helping me with transportation, just involving me in whatever they can help me with. They do it.
Right.
They do it.
So, Rachel, you're one of our medical case managers. Can you describe sort of what your role is in our clinic and how you feel like what's the part of your part on the team and how you help our care team?
Yeah, I think first of all, I really want to recognize that how amazing it's been to be part of a clinic that really does honor and see the value in having case management or social work services, because we, as medical case managers, can do the things that Mr. B was talking about, such as link people to different resources like eyeglasses. We do have some resources for transportation. We actually have some resources for housing. We have some resources for a lot of different things that can help people to be engaged in care and stay engaged in care. So that's kind of my role, is to help people be engaged and stay engaged. And for some people, that means calling them once a week. For some people, that means calling them once a year. It just depends on the person, and sometimes life might be hectic for somebody and they might need some more support, and sometimes life might be all right and we don't need support. Patrick and I, or Mr. B and I, sort of have a joke that I'm almost happy when I don't hear from him for a while, because it means things are going well for him.
Right now we're on an everyday call. Just for right now.
So there's a lot of scientists and researchers in the audience, and one of the things that we talk about are sort of the biological markers. And we talk about the HIV viral load, and that's something that we measure for all of our patients. Do you know what your HIV viral load is?
My viral load has been undetectable for probably 6 or 7 years now. I am very good with my meds.
Well, we are very grateful to you for sharing your story with us. It's really helpful, I think, for our group to see about the things that happen in our clinic. And so, thank you for coming.
Thank you.
So the thing that facilitates the kind of patient-centered and integrated care that we provide in our clinic is sustained federal funding, and it really came from the Ryan White Care Act of 1990. It was signed by the first President Bush nearing the height of the HIV epidemic, when the rate of deaths from HIV was increasing year by year. And it has been sustained now for over 20 years, reauthorized by the second President Bush, and a Modernization Act signed by President Obama. And to put into perspective the level of support that it provides for the things like Rachel was talking about, So if we take all the funds that go toward HIV care in the United States, it comes to about $26 billion. And that includes treatment hospitalizations that are paid for by Medicare and Medicaid. A full $2.6 billion, or a tenth of that, is really the ancillary support services. So that has been the driver of taking patients for whom staying engaged is difficult and making sure that they're living their best lives. This is what it looks like at UW Health. So we're located, it's complicated. I was going to say down the hall, but you have to go up and down 2 or 3 staircases to get there. But we're in the adult subspecialty clinic. We saw over 900 patients last year. And in the past 2 years have started expanding our model to people who are not living with HIV, but those who are at high risk of HIV, and providing biomedical prevention through PrEP. Rachel talked about interdisciplinary nature. We actually have 9 social workers and only 6 physicians. I wonder if there are any other clinical programs at UW Health that have 50% more social workers. But this is really something we consider core to our mission. The data suggests that support for this type of patient-centered integrated care makes a big difference. And this is a study in JAMA Internal Medicine from a few years ago, which illustrates the impact of this. The red bars, so this is about 8,000 patients through something called the Medication Monitoring Program that CDC does, people living with HIV. And it compared people who get care at a Ryan White-funded clinic to those who don't. And Ryan White-funded clinics tend to be larger urban centers that take care of the majority of patients. Something like 2/3 of patients in the United States get care at a Ryan White-funded patient clinic. And traditionally, people that have been uninsured or underinsured almost exclusively received care at Ryan White-funded clinics. So the red bars show that services like case management, substance abuse treatment, mental health, social services, dental service, adherence counseling, all the things that Rachel talked about are really part and parcel of what we do, where it tends to not be the case in the private practice or the funded insurance-funded world. The table on the right shows that the rates of viral suppression overall in the country among people who are engaged in HIV care is about 75%. So 75% of people who are engaged in care have no detectable virus in their blood. In Ryan White-funded clinics, patients who are struggling with various challenges such as poverty and substance abuse have comparable rates of viral suppression to those that don't. And this table shows that it's not the case in clinics that don't have those extra services. So patient-centered care has been a valued tradition in internal medicine, and it's been operationalized in something called the patient-centered medical home, which I'm sure many of you are familiar with. The key concepts of patient-centered medical homes are comprehensive care, patient-centered care, coordinated, accessible, and high-quality attention to evidence-based services. Not to brag, but we in HIV have been doing this for 30 years, even before this was kind of articulated by ARC. And it's been specifically or explicitly kind of celebrated by our partners in Wisconsin at the AIDS Resource Center of Wisconsin, who have the designation of being the first designated HIV medical home, where they've taken this model and really formalized this and saying, yes, we provide models of care that are patient-centered and integrated. And this is from a flyer from their annual report to show that whereas nationally 75% of people engaged in HIV care have an undetectable viral load, at ARCW it's 91%, and it's comparable at our clinic here at UW. Indeed, in Wisconsin, patients living with HIV who are monitored, and this comes from surveillance data, full 92% of people are virally suppressed, which far exceeds the national average. So as Dr. Malbranch mentioned last week, and as we've talked about at previous grand rounds, the most potent intervention to prevent HIV transmission is HIV treatment. And so in a community where the majority, or 90% of people, have an undetectable viral load, person-to-person transmission is low. Wisconsin, up until recently, has been a model of how we've maintained low levels of HIV transmission, at least as it pertains to people who inject drugs. Dr. Malbranch also said that we haven't won this, right? We have a lot of work that we still need to do among men who have sex with men. But this graph shows that across the state of Wisconsin, there have been 5 cases on average per year over the past few years of transmission among people who are injecting opioids and other drugs. That's not 5 per 1,000 or 5 per 100,000, that's 5 cases in a year. Over the past 2 years, it went up, it doubled, and then it tripled last year. And these are still relatively small numbers. This is still 15 cases in a state of 4 million people. But it's concerning. How concerning? When we put in the context of the opioid epidemic, it's actually extremely concerning. This is the what I call the syndemic slide, showing on the right, as heroin overdose deaths have increased, hepatitis C infections, and we talk about hepatitis C and HIV together a lot because they have shared mechanisms of transmission, has really skyrocketed to where a decade ago there were 200 cases of hepatitis C during a year, and now there's over 1,000. The other reason that we ought to be terrified about the potential impact of the opioid epidemic on infectious diseases is what happened in Scott County, Indiana, a few years ago. Southern Indiana, which is mostly rural, had an annual rate of HIV cases of about 5. Actually, I correct myself. There were 5 cases total in this corner of southeastern Indiana between 2004 and 2013. In January of 2015, there was a cluster of 11 cases all at the same time, which appropriately got the attention of state public health and actually CDC, and they started an outbreak investigation. When all was said and done, there were 230 cases, comprising the largest or the most explosive HIV outbreak in the hemisphere, really, in the past 20 years. What they learned was that HIV transmission in this very small rural community was exclusively driven by people injecting a single prescription opioid called oxymorphone. And the ethnographic research they did showed that this was so pervasive in the community. They were poor people living in houses with grandparents and children who were all injecting together and sharing drugs, who were trading sex for drugs, and it spread like wildfire through this community. By the time that the outbreak investigation was written up, and this is from the New England Journal of Medicine, public health had responded, had tested people, and had saturated the market, if you will, in terms of getting people tested, and there have been no new cases in the past year. The slide on the left shows what the response actually looked like. And it highlights the fact that the prevention services landscape was so inadequate, which is what contributed to this outbreak. Needle exchange in the state of Indiana was illegal, and still is, except for an emergency program specifically related to this outbreak. There was no place to get HIV tested in the southern, south of Bloomington, Indiana.
The fire alarm system will be down until further notice.
Good, good. So at least we won't be interrupted by the fire alarm, so we'll be good.
The fire alarm system will be down until
So there was no place to get HIV care. There's no place to get HIV tested in this corner of the state. And all of those things changed once this happened. And the response when this was written up, and they said, well, how do we control the epidemic? Well, it looks a lot like the patient-centered HIV medical home, to be honest with you. The partners that came in, the federal partners, the local partners, HIV testing, treatment, behavioral mental health, treatment for opioid use disorder all came to bear, and they were able to control the epidemic. So in that regard, it's a success. But on the other hand, it was a completely preventable public health catastrophe. So the question is, could this happen again? I think the easy answer is yes, but the more important question is where and when. And this outbreak got the attention of CDC and others to really try to identify what communities in the country are at greatest risk for something like this happening. And this was an investigation that used several dozen different data sources to try to identify and model what communities are the highest risk. And it was published by a researcher who we learned recently is a Wisconsin native, now at CDC, Michelle Van Handel, who looked at county by county across the nation, which counties are most vulnerable to this, based on things like the rate of acute hepatitis C, which is a reportable disease and kind of can be a bellwether of HIV transmission. And it showed that there's profound clustering of vulnerability in the Appalachian region and the so-called Rust Belt. Wisconsin, fortunately, did not make the cut as being in green, meaning the top 5th percentile of high-risk counties. So with this information, a coalition of federal funding agencies, including the NIH, CDC, and SAMHSA, got together to fund a series of large 5-year research projects specifically to target the opioid epidemic. The goals were to identify best practices for implementing evidence-based interventions that could prevent these things. And we were fortunate to be awarded one of these grants with the other sites shown here. Half the sites are in that Appalachian region. One is in the Pacific Northwest and one is in New England. And our partners, the AIDS Resource Center of Wisconsin, which I mentioned earlier as the main clinical provider of HIV care outside of Madison, is also known as having a network of what is probably the largest clean needle exchange program in the country. On the right shows the map that we included in their funding proposal to show the locations of these community-based prevention organizations, and we're using those as hubs to engage people who are currently injecting drugs, some of which are using clean needle services to try to prevent HIV, but more importantly, people in their social networks who might not be using prevention services. The study involves going into the communities, recruiting people who are using clean needle exchange, giving them referral coupons to people in their network who might be what we call secondary exchangers who don't use prevention services, do a seroprevalence study, meaning we test them for HIV, hepatitis C, and syphilis. If they're positive, we provide services to link them to care, and we do a survey that assesses things like their access to health services and their risk behaviors. Phase 2 of the study, which will be starting next fall, is an implementation project. And what we propose to do is inspired by the HIV medical home model to identify that if we were able to do patient-centered prevention services in the same way, learning from these services where people have assistance with care coordination and attention to the ancillary support services that they need, they may be more likely to be engaged in services. And that's the vision. So these are some of the early findings, and thanks to Wajia Akhtar for putting together some of these graphics. The darkly shaded counties are the places where the hubs are, where we're encouraging people, and the other counties are the catchment areas where ARCW has outreach to provide prevention services. The method that we're using is called respondent-driven sampling, whereby one person refers someone in their network. It's also called snowball sampling, and it allows us to make these network diagrams, which can allow us to do things like visualize the data in terms of, on the top, drug of choice. And we're learning some interesting things. For example, on the east side of the state, in the Green Bay, Brown County area, the majority of people are reporting heroin as their drug of choice. On the east side of the state, on the Mississippi River near La Crosse, it's flipped substantially, and the methamphetamine is the #1 drug of choice. So although this is an opioid-related grant, what we're finding is that people that are at greatest risk of HIV infection in certain areas of the state and in certain networks and certain communities are really injecting stimulants more so. So the model for our intervention is the patient-centered prevention home. And we probably don't have funding with a 5-year NIH grant to build new primary care systems, but we thought what we should at least do is make sure that what the World Health Organization considers to be essential preventive services are accessible to everyone who's touched by the opioid epidemic. This is the list of evidence-based practices. We don't have time to go through all the evidence supporting. I am going to talk about 2 of them which seem to be particularly challenging in terms of implementation, which include medication-assisted treatment for opioid use disorder and treatment of viral hepatitis. The bolded services here are things that are currently provided on-site at ARCW prevention offices. These are preliminary data from our client survey in which we just asked people, how easy is it for you to get access to this service or this service? And they're ranked here. And the services that are provided on-site at the needle exchange offices, like it's easy for me and my partners to get condoms, it's easy for me to get clean new syringes. The majority of people says they strongly agree or some would agree with that. The things where the most work needs to be done is at the top. If I wanted to start medical treatment for opioid or heroin addiction, I could easily get buprenorphine. A minority of people said that would be easy for them to do. So we don't have, I would love to have another guest to sort of, again, show this juxtaposition of how well people living with HIV are served and how poorly people living with opioid use disorder who do not have HIV are served. But we do have a recent experience in our study that I just wanted to share for a moment. One of our study participants came in, went through the procedure as I mentioned, and underwent an interview. And in the course of that interview, when he was answering questions about how easy or hard it is for you to get medications to treatment, he said, you know what, I would really like to be on buprenorphine right now, and I don't know how to do this. In fact, he went to a clinic and was told for various reasons that he wasn't eligible because he also used alcohol. There was a litany of exclusionary criteria. So our researcher, who is not a trained social worker or case manager like Rachel is, said, well, let's see what we can do, and spent the rest of the afternoon calling all the places that one could get medication-assisted treatment in Outagamie County, and needless to say, was not very successful. San Francisco, in the early part of this century, implemented what they call the red carpet treatment, which is if someone had an HIV-positive test anywhere in the city of San Francisco, they got someone escorting them on the same day within hours of getting their positive test to a place where they could get linked to care. This is not red carpet treatment. We don't have this currently built. But for reasons that I'll show, it's even more important for people who are at risk of dying suddenly from opioid overdose. The qualitative research involves in-depth interviews with individuals. I wanted to share some of that. For example, we asked them to tell us what it's like to receive health care, just general health care in the area where you live. One person said, you go to doctors and they look down on you. My God, that's the most ridiculous thing. It's embarrassing. It makes you feel worthless. Less than when you get a doctor going, why are your veins so knotty? And you have to tell them you're an IV drug user, and then that just destroys any relationship you would have with certain doctors. Because if you tell them that you're sick or you need this or you need that, the first thing that they jump back is to, oh, well, you're an IV drug user and you're just going to come in here looking for pills. It's kind of hard as a physician to read this and to hear this. But it's important to share it with you, I think, because unfortunately this is the rule and not the exception among the voices that we're hearing and the people we're engaging. On the contrary, when we ask them what's it like to get care or get services at this needle exchange program, they say things like this. Well, what's it like? It's wonderful. They don't make me feel like I'm an expletive piece of expletive drug user. It's kind of weird, to be honest with you. So all the ladies here, this guy, they're all awesome. They make you feel like, what can I do for you? What do you need? You need anything else? That's awesome. The ways in which that the stigma and marginalization has been internalized by people that we're studying is really profound, and I wanted to share these as well. I mentioned that there's a big disconnect between people who are regular clients of the prevention services at ARCW and those that aren't. And our goal was to actually get more people who are so-called secondary exchangers to come and participate. And this one person had a challenge with that. He said, I was supposed to bring like 5 people, but nobody would come. They're just scared to come here because they feel like they're going to get arrested because of being a user. So we shouldn't have to feel scared. I know it's illegal to do the drugs, but wouldn't they rather us be doing them in a safe way than freaking dying and getting diseases and infections? The other thing we learned, and we had high hopes of doing some sophisticated epi-analysis with these various sources of data like syndromic surveillance and EMS calls. But what we're disappointed to learn was that most people who overdose and get revived with naloxone, no one calls 911. And that was surprising to me, and so we've investigated that a little more, and this is one of the voices trying to put that into context said this. He said, I've been in that situation. Only once did they call 911 for me. But I always told them, if I overdose and I don't come back, just go drop my body off in the alley. Don't say nothing. If anything, call my mom or a sister, but I don't want the stigma attached to me that they got a junkie overdosing in their house. I'm going to switch gears and talk about the evidence-based interventions related to opioid treatment. As many of you know, medication-assisted treatment, there's several FDA-approved medications. Methadone is the most well-established form of treatment. It's a pure opioid agonist, and it's available only in licensed treatment facilities for maintenance program. Naltrexone can be an oral daily tablet or a monthly injection, which is a pure antagonist, which blocks the uses of or blocks the effects of opioids. And then buprenorphine, which is unique in that it's an agonist-antagonist. It's given as a daily administration, but more recently also can be given as a 6-month implant or monthly injection. And there's a lot of hope for buprenorphine because, unlike methadone, which requires it to be administered at a licensed treatment facility, it can be given in primary care settings. So any provider who has a DEA license and can prescribe medications can go through some additional training to become a buprenorphine prescriber in any kind of primary care setting. So there's a lot of hope that it might be something that could be implemented on a wider scale and get more people access to opioid treatment. So this is one data slide sort of about the impact of medication-assisted treatment after people who have non-fatal opioid overdose. This was a study from Massachusetts using their all-payers claims database. We have one of these in Wisconsin. Pretty much all payers of healthcare share pooled data and allow research on utilization and healthcare access and things like that. And so this research group did a retrospective cohort study of people who had a non-fatal opioid overdose and presented to any hospital in Massachusetts. And the first lesson is that if you have the unfortunate of having a non-fatal overdose, you have a 1 in 20 chance of dying within the next year of a fatal overdose. The goal of this study was to show, is that risk of fatal overdose after you've had a non-fatal overdose modified in any way by whether you got prescribed medication-assisted treatment? And it turns out that it was. People who received methadone maintenance had only a 2% mortality. I shouldn't say only, that's still a high mortality because they're predominantly young people. Buprenorphine, 1.8%, and people who received naltrexone had a 1% chance of dying. If you compare the risk of mortality to the no MAT, by which I mean medication-assisted treatment, and the naltrexone group, it gives you a number needed to treat of 25. So number needed to treat, then how many people do you need to treat to prevent one adverse effect? To put it in perspective, 25 is pretty good. I remember learning about critical appraisal of the medical literature as an internal medicine resident and finding that a useful metric. And it always hit home, in my experience, the specialists who were the most fervent and the most enthusiastic about implementation of evidence-based practice like this were cardiologists. And I remember one CCU attending in particular who made us feel like if every person admitted to the hospital for acute coronary syndrome was not prescribed a beta blocker, an aspirin, and a statin at the time of discharge, you were, well, at best you were prescribing substandard practice, but at worst you were bringing shame upon your profession and your family. So this compares pretty favorably to that, the kind of care that we give to people, or the efficacy of the interventions that we give people after MI. But unfortunately, in this Massachusetts study, only 10-50% received MAT at all in the following year. And this graph shows that they weren't much more likely to receive MAT the year after their non-fatal overdose as before. This is a separate kind of study, but also related to buprenorphine, and I think this is a particularly interesting point that I'd like to make. This was a smaller study, but a randomized study in an HIV clinic in Baltimore, and the randomization was that people who had HIV and opioid use disorder and were thought to benefit from medication-assisted treatment, they were randomly assigned to two conditions. One is to get MAT by their provider in their clinic where they receive HIV care. The other was to go literally across the street and get it at a partner clinic. So on-site, co-located versus referral. And the outcomes at 12 months showed that people who were referred to on-site care were almost twice as likely to receive medication-assisted treatment. They were quite a bit less likely to have positive urine screens for opioids. And two of the things that I think are interesting that aren't necessarily related to opioid use, one is that they were more likely to show up for their HIV care appointments. And the second was that they were less likely to use cocaine. So I think the message from this is that patients prefer and want to get patient-centered care, co-located care. And the other is that when we engage people in a person-centered way and take care of their addiction as it's one of their medical problems and not something that's a problem that someone else needs to deal with, there's ancillary benefits. Okay, next we're going to talk about hepatitis C. And as I mentioned, the reason we talk about hepatitis C, one reason is that it's a fellow traveler. Among people who inject drugs, the risk of HIV goes up if they use non-sterile syringes, obviously. The rate of hepatitis C is substantially higher than this. Hepatitis C is more easily transmitted and very high prevalence of hepatitis C infection among any community of people who inject drugs that's been studied in the past. The other reason is that when we're talking about epidemics or syndemics, is that it's getting worse. In 2006 was the first year that deaths related to hepatitis C surpassed deaths related to HIV in the United States. The same research group that presented this a couple years later said, well, actually, it's continued to get worse. As of 2012, hepatitis C was responsible for more deaths than all other reportable infectious diseases combined. So this is a bad and a growing problem. When I was in medical school, this was a disease of baby boomers, and we were trained to treat people who were born in that birth cohort. That's no longer the case. Hepatitis C is now an infection of young people who inject drugs. And so thinking about what can we learn from HIV and apply to other conditions, this is a great opportunity where we could use the treatment as prevention paradigm. If we treat people for hepatitis C, they are cured. They're no longer infectious. And there's potentially, therefore, a very powerful way to reduce the spread of hepatitis C by treating people who are most likely to transmit the virus. And you have to look kind of hard to find places where this is being done. But there is one. There's 3 now. But these are data that from one of the first countries that has really taken seriously the idea that we can try to eliminate hepatitis C by treating people who inject drugs. And this was in Iceland. And similar to what's going on in North America, injection drug use is getting worse over the past few years. At the same time, though, they made a conscious effort not to just make treatment available to people who inject drugs, but to prioritize people who inject drugs for hepatitis C treatment. And they saw this dramatic decrease in the incidence of new cases of hepatitis C. In the press release that accompanied these findings, this, I'm not going to attempt to pronounce it, Dr. VR said, people who inject drugs are the key drivers of hepatitis C infection in Iceland, and this population should be a focus of treatment scale-up. We'd like to emphasize and encourage collaboration between addiction treatment centers in both screening and treating hepatitis C. This is key to the success of reaching the population in focus. And the data support this approach. Some people have raised concern that, well, if we're treating people with hepatitis C, because we know their lives are chaotic and they might need extra support, it doesn't work as well. But the data are very clear that that's not the case. There's many studies like this, but this one shows that if you look at people who are injection drug users and people who don't inject drugs, the rate of cure on any given regimen is comparable, and in some cases actually a little higher. And summarizing all the data about the effectiveness of hepatitis C treatment for all people who have hepatitis C, the AASLD and IDSA joint recommendations say treatment is recommended for all patients with chronic hepatitis C infection, except those with a short life expectancy that cannot be remediated by HCV therapy, liver transplantation, or other directed therapy. I kind of wish they would have used a period because those are fewer cases. The message I would like to, that I take away from this is that any person with few exceptions because they're near death is better off having their hepatitis C treated than waiting and not getting their hepatitis C treated. This is not at all what we're doing in this country. And these are data by our graduate student, not yet Dr. Carly Hochstetter, who's worked with our group for the past few years, a true example of true shoe leather epidemiology. So our group received an ICTR pilot several years ago to pilot, which led in ways to this rural opioid study where we were out in the community doing rapid hepatitis C testing. And what Carly's project was to try to track down everyone who's screened positive, and there were about 80 of them, to see in the next year how many people got linked to treatment, how many people got started on treatment. And despite a heroic effort which involved knocking on doors in Milwaukee neighborhoods, she could find only 2 people that had been linked to care and started on treatment. So despite the guidelines that show that everyone benefits from treatment, I haven't talked about this, but the other issue is that hepatitis C is actually now really easy to treat. New treatments are pan-genotypic, so you don't need to know what genotype and virus the person has in order to cure them. It lasts 8 weeks, and close to 100% of people are treatable with a once-daily regimen. So despite that, we're not getting much people treated. It's hard to get the drug into the patient's hands, and this is one of the reasons. If a provider wanted to prescribe any hepatitis C treatment to someone who's on Medicaid, for example, you have to fill out this form. This is page 1. This is then page 2, and that's page 3, and there's actually page 4. But page 2 is what I want to highlight. And question 20 asks the providers, does the patient have a history of alcohol use disorder? And you have to say yes or no. And then when did the patient last consume alcohol? Question 21 is, does the patient have a history of injection or IV drug use? And then you have to say yes or no. And is the member currently a participant in the recovery program? And so they ask this just because, by and large, if people are injecting drugs, they don't agree to pay for treatment. And this makes it, it's not to say that people are never, and to be fair, that these guidelines are implemented flexibly. I think if people are engaged in treatment, and there can be some back and forth, people are getting treatment, but it makes it very difficult to advocate for your patients when this is sort of the standard that we have to, the hoops that we have to jump through. So the Harvard Center for Law and Policy Innovation sort of took inventory on a nationwide level of what are these restrictions. They refer to them as discriminatory state Medicaid restrictions. I think, to be fair, the intention is not to be out for overt discrimination, but to save money. But to save money by not treating people. And so in the places where these restrictions have been removed. In the first place was actually Washington State. It was done through a lawsuit. Patient advocate group said, you know, I have stage 1 fibrosis, and the IDSA says I'll be better off if I get my hepatitis C treatment. Why are you saying I can't get treatment if I don't have stage 3 fibrosis? And the judge agreed and says, you know, as the way the law is written, that's not fair. So they told the Medicaid program, you have to pay for treatment for everybody. The state Medicaid director said something to the effect that, well, that would cost more than all we spend on all of healthcare for the Medicaid population. And the judge said something like, that's not my problem. So a number of states, including Illinois, as of a couple weeks ago, have removed these restrictions. To my knowledge, none of them have been done outside of a lawsuit or an explicit threat of a lawsuit. But I think there's hope as the data accumulates and advocacy progresses. So this is my best one-slide answer to the question posed in the title of the slide, is what can we learn from HIV care that can help us treat our way out of the opioid epidemic? And it's patient-centered care, coordinated, that meets people where they're at and pays attention to all the various challenges that people need. So the way I compose this slide is, you know, this is the medical home model. This is from the earlier slide. This is what ARCW and other places really celebrate as the standard of care for treating people living with HIV. An ARCW client who comes in who doesn't have HIV but injects drugs, this is the current model. They essentially have a prevention specialist, which is PS, and they have a support staff of 1, and I don't want to underestimate how impactful that relationship is. The quote that I showed you, so these are very valuable. A lot of times, patients who are engaging with our studies say, I feel like nobody else cares about me. I feel like no one else cares whether I live or die. But I come to this needle exchange program, and they care whether I live or die, and they give me things to help me live a healthy life. So this is, although it's a much less complicated model, it doesn't necessarily facilitate all of these things. So our vision for our study is that we take what works here, and we build upon what's very valuable here, and we figure out ways to build out the additional support to make sure that everyone who is injecting drugs has access to treatment so they can get into remission, gets tested and treated for hepatitis C and HIV care. If they have not been immunized for viral hepatitis, for hepatitis B and A, we can take care of them. And this model doesn't exist yet. But I think it could, and I think it should. And I think we have a roadmap on how to get there. We have funding models, which we know how to support this. We just need to find the political will to build it. So on the topic of political will, I wanted to end with a quote or a video clip. And I'll set this up. This is from a documentary about the activist organization called ACT UP, which in the 80s and 90s was responsible for a lot of direct action campaigns to lobby agencies like the Food and Drug Administration and the NIH to change the way they do business to allow for more rapid and efficient development of treatment for HIV. And the person who's going to speak here is Larry Kramer, who was a playwright and was one of the founders of and a leader in the LGBT community in New York.
Our last speaker is Larry Kramer.
Why don't you answer the charges?
Bill, you're going to have a chance to talk, all right? Everybody's going to have a chance to talk.
Don't lecture me, you stupid, lazy, incompetent shithead.
Bill, everybody got the flyer. There's going to be a question and answer period.
You can't just lick his ass before he talks. Let him answer.
Look, there are a lot of people in the audience who want to ask and talk about treatment, and I think it's important that we allow that to happen.
Oh, now, we're going to dictate free speech now?
You're the one who's interfering with speech right now.
I don't have the GMAC or whatever AIDS pimp operation is paying you. You're making the same point George Bush did.
Plague! We are in the middle of a plague. And you behave like this. Plague! 40 million infected people is a plague. We are in the worst shape we have ever been in. All those pills we're shoveling down our throats, forget it. ACT UP has been taken over by a lunatic fringe. They can't get together. Nobody agrees with anything. All we can do is field a couple of hundred people at a demonstration That's not going to make anybody pay attention. Not until we get millions out there. We can't do that. All we do is pick at each other and yell at each other. And I say to you in year 10, the same thing I said to you in 1981 when there were 41 cases. Until we get our acts together, all of us, we are as good as dead.
So this is still streaming on Netflix, so I recommend that you watch it, but if you'll forgive the spoiler, I think it's worth noting that Larry Kramer is still alive at age 83 to his own professed disbelief and still writing. And I've reflected on this because two things happened last week on the same day. For those of you who were here with us last week, Dr. David Malbranch, who's a true hero in the field of HIV prevention. And we had a community gathering just to recognize World AIDS Day on Thursday night before his talk on Friday. And that same day, the CDC came out with their updated estimates of overdose mortality for the United States. And the New York Times because this is what they do, made a much more attractive way to visualize the data than the CDC did. So that's what we're showing here. And this shows drug overdose deaths from 1980 to 2017. The year that Larry Kramer said we are in the worst shape we've ever been was 1991. HIV/AIDS got worse and peaked 4 years after that, 50,000 deaths related to HIV/AIDS. 70,000 people died of opioid overdose last year, and it was 60,000 the year before. And I think we were hopeful that it would start to plateau, but it's not plateauing. This is the epidemic of our time. This is an emergency, and we need to do things. The other thing that gets me both somber and also inspired, reflecting on the video clip, it was the level of passion and social capital that this community had to stand up for itself and to influence policy. Through our work now, we've visited sort of community events or opioid task forces in the 6 counties, and the people who are likely to die from opioid overdose are not at those meetings. So that tells me that, to the extent that activism and that advocacy has moved HIV care forward, that's going to need to come from someplace, and it's not coming from the patients who are affected by opioid overdose, and I think it can in part come from us. So that's our challenge, and I have 3 suggestions on how we can accept this challenge. The first one is that any of us who prescribe medications in this room can prescribe buprenorphine. And I think the evidence showed that you could potentially save some of your patients' lives if we were to learn how to do that. You do need to get additional training, and it does cost money. But, oh, wait, it doesn't. The MATEC, so our program, the AIDS Education and Training Center that Jim Sossman is the PI of, is sponsoring a training event here in Wisconsin. They're doing one in Milwaukee and one in Madison. So all of you are invited to participate and to get your buprenorphine waiver so you can prescribe treatment for opioid use disorder. There's flyers in the back. They're across from the table where the donuts were. So walk out that way, you can pick one up. Similarly, and we didn't talk much about naloxone, but naloxone clearly is an important tool, and this is potentially an important quality metric of our patients who are getting high doses of opioids, who are not necessarily using them recreationally or injecting drugs. But at UW Health, we can do a much better job of making sure that all of our patients have access to naloxone or bystanders. The second is to advocate for fair policies. And I can think of no other way to say the way that we're treating hepatitis C in Wisconsin is unfair. And this is the committee, the Wisconsin Medicaid Prior Authorization Committee. They meet quarterly, and they accept public testimony. So we're going to be preparing some information for that. And if any of you are interested in contributing to that or signing up on a joint letter, feel free to email me. And then finally, anyone can treat hepatitis C. We should all do it. There's even a smartphone app. You just go here, you say, this is my patient's numbers. They tell you what to do. And I think the more demand for it, the more providers who are saying, I want to treat my patient as hepatitis C, the easier it will be to say that the restrictions should be limited. Thank you for your attention, and good luck to all of us as we continue to work on behalf of this epidemic.
Thanks, Ryan. That was wonderful. We have time for questions.
Thank you for those comments.
So the growth of the overdoses from methamphetamine is increasing exponentially as well, not at the point of the opioid deaths. But what is the impact of a lack of a medication-assisted therapy for methamphetamine? What is the effect of that on your algorithm or your proposed approach to treating these patients or preventing the disease?
Thank you. The question is picking up on the fact that we're finding that a majority of patients in some of our communities are injecting methamphetamine rather than opioids, and we don't have really effective medication-assisted treatment for that. I think it's a big concern. I think the further west you go, if you cross the river to Minnesota, it's even more of an issue because methamphetamine is by far their drug of choice. So for the issue of preventing HIV and hepatitis C, I think the issues are comparable. We need to engage people in all the types of evidence-based prevention activities that we know, which can include harm reduction services like clean needle exchange, biomedical prevention like pre-exposure prophylaxis, particularly for people who have both drug injecting and sexual risk factors. But the fact we don't have something analogous to buprenorphine makes it a challenge. But I'm encouraged that, like the Baltimore study showed, that when we treat people like patients or treat them like people and care holistically about their health care needs, in that group, even though we didn't treat we didn't treat the right receptor, right? We didn't treat the opioid receptor, their stimulant use disorder went down. So I think we have a lot to offer people by engaging them in patient-centered healthcare, even if we don't have medication treatment for their specific substance use disorder. Although it is more of a challenge, I agree with that.
Just with the opioid epidemic for awareness, we at the VA here have mental health, all psychiatrists, waivers. We have very easy access, same day, next day for Savant initiations. And we are going on a pilot program into primary care ultimately to make sure any of those barriers to access. There is a UW grant right now too that has a phone number, consultation
think the question of where are dollars best spent at this moment. We had some discussions just last night. As some of you may know, I have familial ties to the Department of Emergency Medicine. So we were talking with providers from the emergency department, and there's a lot of interest in treating people with buprenorphine who either come in because they want treatment for their opioid use disorder or they're having withdrawal syndrome and they don't want to use heroin. But the big challenge is, while it's easy, as you'll all find out when you take the course, to induct somebody on buprenorphine, it really works best when it's lifelong treatment, or if not lifelong, sustained treatment, and is coupled with behavioral health care. The emergency department is not set up to do that well. So a necessary first step is for us to get more providers to be able to treat with this useful medication. But the second step, and I think this is where I would put our resources most urgently, is that we need to have a home then to plug people into so they can get ongoing care and support. Whether that happens inside our existing primary care network or whether we have a new niche services where kind of carved out MAT providers, either would work. I think the data suggests that patients like to get treatment for their opioid use disorder from their doctor who knows them well. So I don't know the best way to do that, but I think we need the ongoing getting people started is very important and can save people's lives, especially after someone has a non-fatal overdose. Their risk of having a fatal overdose is high, it's highest in the next week and month after that. So that shouldn't stop us from getting people started on buprenorphine in that acute setting. But it's not enough. It's not enough to prevent someone from relapsing and having a fatal overdose 6 to 12 months later. So I would say we need to focus on outpatient supportive care for people who have acute needs to be on medication-assisted treatment. And my vote would be that we build that in our existing primary care networks.
As you know, there was recently an article in the Annals that documented the experience of emergency physicians, I believe in New Bedford or not New Bedford, New Connecticut, that ER physicians starting bupropion when the patient comes in with an overdose is safe and is effective in reducing mortality. And that you can initiate bupropion on an outpatient basis. My question is this: at UW, you would hold bupropion therapy to opioid addicts or have a medication use disorder who also use cocaine or marijuana or crystal meth?
So the question is, do we withhold from people who have kind of co-occurring substance use disorders with a non-opioid? I can't speak for the institution. I know that some organizations do that. In fact, the anecdote that I discussed briefly about our study person in Allegheny County, that was why he was turned away, is because he had an alcohol use disorder. To my knowledge, there's not regulations, nor is there a sort of scientific reason why we should do that. And I think that, again, getting back to the co-localization service, if we treat their opioid use disorder, can only help by providing patient-centered care. It is more of a challenge. In my limited experience as a buprenorphine prescriber, patients that have stimulant use disorder struggle. It's not a magic bullet, right? They need a lot of support. So I think it makes it difficult to treat, but I see little downside, particularly if you can prevent someone from having a fatal overdose. Thanks. Sure. Thanks for the comments. I think there is a sentiment that replacing an opioid, someone who has an opioid addiction with an opioid-based treatment, is substituting one addiction for another. I guess my responsibility, I don't see it as substituting one addiction for another. I see it as substituting one opioid for another. But this isn't, and I agree it's not an easy solution or a solution in all cases, but I think the paradigm is that this is medication-assisted treatment. It's an addiction treatment. There's good data that long-term medications as part of treatment is better than addiction treatment without medications. And so, yes, we're still stimulating people's opioid receptors, but I think the way that I think it makes sense to me is the way DSM-5 has categorized it is really being explicit about there's use and there's use disorder. And I don't know, the term addiction is getting less emphasized in that setting, but we're treating people's disorders. And if we're allowing people to keep a job and not inject drugs and put them at risk, using the substance is secondary to the fact that they're using or disordered by their use of the substance. So I find it helpful to think about it that way. But I agree with the sentiment that you expressed, that it's not a magic bullet, and it's not sufficient by itself. So thank you for the comment, and we have more discussion about this.
I appreciate the next question. The issue is, if it were substituting one addiction for another, then a patient on a stable dose of buprenorphine would exhibit preoccupation, craving, use beyond the amount intended, spending huge amounts of time engaged in the behavior, breaking rules, not going to school, not going to work, committing crimes, in withdrawal. If you look at the criteria for addiction, the criteria for addiction are no longer present in a patient stable on maintenance treatment. You have substituted an opioid for another. You substituted a physical dependence for another. But you have not substituted an addiction for another, because addiction manifestations go quiet.
Yeah, I think I probably have to say dependence more than.
Thank you for clarifying. You articulated the response that I wish I would have been able to say very well. So I think we're out of time.
Please join me in thanking Ryan again.